one more thing. Okay, perfect. So let's begin. So the first slide that we have are the objectives that we're going to cover today. Identify components of the skin, hair, and nail assessment. Identify nursing care for common skin disorders. Differentiate between the various types of burn injuries. Prioritize emergency nursing interventions for the burn patient. Identify nursing care for minor burns, and identify nursing care for the patient with extensive burns. As I said, probably 10 questions for skin, hair, and nails, and 20 will be for burns. So don't forget to study that. Okay, you've seen this picture already. We talked about that in Brad's lecture, so we're not going to cover this in depth. We have the epidermis, the dermis, and the hypodermis. Just there as a brief review. Let's go now to some of the components that you need to ask your patients about for their health history. Remember, when we do a comprehensive, focused system assessment, it involves two things. It involves a health assessment and the physical assessment. So there's, in every lecture that we talk about, two different components, health assessment and physical assessment. So there's different things that can affect a person's skin, hair, and nails. First of all, is age. So as a person ages, you know this from fundamentals, that the skin gets thinner and drier and more fragile, making it very susceptible for irritation. Also, current medication that a person may be on. Many medications cause skin reactions, such as hives or photosensitivity. So it's very important to ask the person when they come in, even though we're dealing with skin, we ask them about the current medications that they are on. So in any health assessment in any patient, it should include obtaining information about what the medication list is that the patient is taking. Also, familial history, dryness, rashes, itching, psoriasis, eczema, dermatitis, hives, allergies, all of this may be hereditary. I can remember my dad had eczema so far. Oh, can you believe this? My mom and dad met in Hawaii. My mom and dad married in Hawaii. They lived in Hawaii for a year, and then my dad had to transfer back to the States. He was with the FBI. But why? Because his eczema, that he was so allergic to the foliage over there. I could have been born in Hawaii. I could have learned to surf. I could have had a great tan my whole life. But no. California. Also, occupations. A person may be exposed to toxic chemicals or fumes. Occupations can be the cause of skin disorders. I always ask too the person, are they using any new soaps at home? Are they using any new detergents at home? Have they tried any new lotions at home? That type of thing. One of the most important things too is, have they had any recent travel outside of the U.S.? New food that they're being exposed to, or new foliage or an environment can contribute to skin disorders. Plants, animals, chemicals, all these type of things, even carpeting can affect the skin. So you want to have a pretty thorough health assessment when you're assessing a skin. So when a person first comes in, you know that we do an initial assessment. We look at them. They see what we want to see, what their general appearance is, if they have good hygiene, if they smell, are they clean, do we see visible dirt on them? We want to see the general integrity of the skin. Are there a lot of breaches in the integrity? Are there skin rashes? Are there disruptions? And we want to look at color, moisture, dryness, temperature, this all, texture, turgor. We need to be very, very careful that we do a very thorough assessment of the skin. Turgor is either defined as firm or elastic. So I want to show you guys, this is what an old person happens, what happens with an old person, why you check up above the clavicle for a person, for an elderly person's skin trigger. So watch it, how it tints, how it stays up, up, up. It's not necessarily because I'm dehydrated, which is mostly what happens when a person has poor skin trigger, is that they are dehydrated. But for me, believe it or not, hard to imagine, but I'm living proof that as a person ages, the adipose tissue in their body starts to receive so it's very easy to have tinting. But decreased turgor is seen with dehydration or normal aging. We also want to look for edema. Dependent edema will be found in the lower extremities. For patients that are usually sitting in chairs all day long, and they're not walking around, or for those that are bed down. But when we talk about dependent, we're talking dependent healthcare means medication. So, it means gravity. So anything that is closest to you, that is going to have the greatest pull gravity. So if edema is suspected, what we want to do is palpate those areas to assess or mobility or consistency. And when there is pressure from fingers that leaves a little dimple or an indentation there, then we call that pitting edema. But normally, skin should be very smooth, have no abrasions. It should be dry. It should be well hydrated and warm. All right, so there's different kinds of lesions, and usually when you're documenting, you don't remember these names, so you just document lesions. But you need to be familiar with these different types of lesions. There's primary lesions and there's secondary lesions. So let's look at the primary lesions first. So the first one is a macule, and you'll see that a macule is pretty much like a little freckle. It is flat, it's non-palpable, but it is a discoloration in the skin color. It may have a different size to it, it has different shapes, it has different colors. It's usually smaller than 1 centimeter. And you can get this with rubella or scarlet fever or freckles. So be able to recognize that description as being a macule. The next one, you can't see very well on this PowerPoint, because whenever we upload PowerPoint, the pictures go cattywonk. But this is a papule. So a papule is a raised lesion. This one is flat. This one is raised. It is also less than 1 centimeter. And it's usually due to a superficial thickening of the epidermis. And you'll see this with ringworm. You'll see this with a wart or a mole maybe. But it's called a papule. This is called a nodule. It's also a primary lesion. And it is a solid, it is elevated, it is larger and deeper than a papule. We talked about blister type of lesions here with burns, but this is called a vesicle. A vesicle is raised, it's fluid filled. It can be up to 1 centimeter in diameter. And you'll see this a lot of times with poison ivy or shingles or chicken pox. This one here is called a bulla, And a bulla is also a fluid-filled vesicle, but it's larger than 1 centimeter. And you'll see this a lot of times with burns or contact dermatitis. This one over here is called a pustule, and it is a small elevation of the skin. It can be a vesicule or a bulla, but it's filled with pus. You'll see this with kids that have impetigo or acne. This one is a wheal, and it's round. It's got some erythema around it. It's elevated off the skin. It's caused by dermal edema. And it's usually lighter in the center and then red in the periphery. And you can kind of see that. This is due to hives. Now this one over here is plaque. It looks a lot like hives, but this is really different than a hive because this is elevated just like a hive. It's white in the middle and then got red surrounding it just like a hive, but this has got kind of a crusty dryness to it. It's greater than 1 centimeter, and I have to tell you, this is rub up against this layer of dry skin will come off. And this is seen a lot of times in psoriasis. I don't know if Rachel taught you about cysts, fundamentals or not, but a cyst is a closed sac that is consists of pus that can be semi-solid, it can be solid, it can be liquid, but it's glanced and removed. All right, so then there are secondary lesions, and secondary lesions usually are an evolution of a primary lesion. So a primary lesion is, we talked about the different kinds of those lesions, but let's look at the different kinds of secondary lesions that usually, like I said, generated from a primary lesion. So the first is a scale, and a scale is a dry exfoliation of dead epidermis. It looks like a snake is shedding. It's just got this dry skin that is a result of inflammatory changes. So this can be cradle cap, it can be psoriasis, that type of thing comes from. Over here is crust, which is a scab that forms by dry serum and pus or blood, and it's infected dermatitis or impetigo can cause this as well. Excoriation, as you see here on these fingertips, a lot of nurses will have excoriation of the fingers because they do so much hand washing, but it's these are traumatized abrasions. So when your hands get really, really dry from hand washing, they can kind of break open a little bit, crack that type of thing. And those abrasions start to cause the skin to peel. This is a fissure, and a lot of times you will see fissure in very, very dry skin, or it's with people that wear their flip-flops all the time in the summer. The skin is very, very dry, and so it will crack. And oh my gosh, it's so painful. A lot of this can be caused too by going barefoot all the time, and fungus, and different little pathogens, the grass and the dirt and that type of thing, which can also cause the skin to get really dry and fissures or cracks as well. The next one is an ulcer, and this occurs when there is an erosion of the surface of the dermis or of the mucous membrane. often it causes this deep crater in the mouth. Over here we see lichenification, and this is usually when a person has had some area of their skin that has been repeatedly irritated. It becomes very thick, it becomes very leathery. It's usually the result of continuous scratching or rubbing. People wear these collared shirts. Anyway, so they're wearing their shirts around their neck, and maybe they're starched, and it's rubbing against the neck. So a lot of times you'll see this on the neck, but you'll also see this if people have radiation, internal radiation, that it truly damages the skin, burns. Then we have a keloid here, and what we have with keloids is that you have an enlargement of the fibrous tissue that replaces dermal tissue after an injury. Keloids are more common in darker skinned people, but I have to tell you, I find a lot of keloids lighter skinned people. Oh, it just depends how you're built. So you can have this elevation, and minor scarring will have an elevation. But a scar looks like it should be flat. The edges are well approximated, and no elevation to it. But with keloid, there is this overgrowth of fibrous tissue. So some people will go and have these removed, have them lasered off to be removed. Similar to people that are having laser treatments to some of their overgrowth of scar tissue after being burned. Okay, so here is kind of a little from the book, a little picture from the book that talks about being, when you're inspecting the skin, you're assessing the skin. You are assessing for by inspection, observation, but you're also assessing palpation. And so we're talking about elevation here, and you're looking at, and so when you document that it's palpable or that it's unpalpable. We also have vascular lesions, and vascular lesions are discoloration as a result of an injury to the vascular system. So you should all be very familiar with ecchymosis. Anyway, ecchymosis, it's a bruise that, is caused by leaking capillaries or blood vessels underneath the skin. Trauma. And it'll change color from blue to black to greenish brown or yellow as it's healing. This is very different than purpura. Purpura is a collection of blood in the subcutaneous tissue that is a solid purple, deep purple discoloration of the skin. And it's not going to change colors like eczema. It's going to stay this dark purple because there's no real injury to the tissue. What is happening here is that the capillary is leaking, or the vessels, the very small arterioles, or venules are leaking. So it'll stay this deep purple. This often is the result of a person being on blood thinners or anticoagulants. Next one is petechiae, and petechiae is very important because, yes.
Megan Birmingham had a question. She said, does purpura go away or does it stay in the tissue?
It will eventually get reabsorbed into the body and disappear. However, that doesn't mean that there won't be another one very similar to it right next door. Or they can get extremely large. So yes, it will go away with time. But if a person's on blood thinner, this is probably going to be a recurring problem with them. They do go away. I have them. I part of being old, I gotta say, I can come up against table, and I'll end up with a bruise very, very easily. And I'll look over on the other arm and I'll have some purpura, and I have no idea where it came from up here. So yes, they come and go, but doesn't mean that you're not going to have one again. Okay, so petechiae is real important because there's very small hemorrhage, again, by the capillaries bleeding. It can be because the person's on anticoagulant. But one thing that you really have to watch for, especially if you're going into pediatrics, is that this can be the first sign of, now I totally lost, meningeococcemia. There you go. Meningeococcemia is a horrific viral disease that can, and it can begin with petechiae in the lower extremities. And within 24 hours, a pediatric patient, and we're talking babies, non-walking babies, to toddlers to infants, clear up to college-age kids, can acquire the disease, and they'll end up losing limbs, total limbs. Within a short period of time, we're talking 24, 48 hours, because it affects them. So you want to be very, very careful. Petechiae, usually if it's an elderly person caused by capillary bleeding, isn't that big of a deal. It can become apparent if somebody is bleeding internally. So that's something that you want to look for too. But in pediatric patients, you want to get doctors. Okay, this is a cherry angioma, and this is where papilloma. Sorry, I'm sorry. Carolyn's bringing me lunch right now. I love Carolyn, bless her heart. She knew it was going to be one of these. Here, she brought me my Diet Coke. That's all right. Anyway, this is an extension of a vessel, a blood vessel that is now become external and is an elevated place on the skin. As people age, they will start to develop these, which are really, they're non-painful. You don't, they're not even there, but you don't even know that they're there. But I tell you, if you come across them when you're shaving your legs, you're going to bleed like a stuck pig. I'm just saying. Okay, and if you guys do have any questions, I can't see your questions right now because of this setup. Oh, don't you love it? So please feel free to butt in and ask any questions, because I know it's important to get an answer while we're there. All right, then other types of skin lesions that we're looking at are different kinds of skin cancers. Megan, I see you. Did you need something?
Sorry, I just unmuted myself. But everyone is saying that they hope your drink has rum in it, so.
Me too. Of course, something that, anything. It can be anything. Would be very helpful right now. Thanks for all your compassion and your empathy. All right, so types of skin cancer here. There's 3 different types of skin cancer. So we have basal cell, and we have squamous cell, and then we have the infamous melanoma. Basal cell and squamous cell are very, very slow growing. And so they don't really cause us much concern at all. In fact, they look just like this, only a lighter brown. And they can be bigger than this. They can be on the face. They can be anywhere. They don't have to be in the sun to develop. They just develop. And they're ugly as sin. I hate them. Got a couple of those myself. And I've got in to get them removed before, and the doctors won't remove them. It's just a cosmetic. And so, am I going to wear my bikini? No, not. So I'm just saying. So basal cell, squamous cell, they don't really grow fast enough to be of concern. But melanoma, on the other hand, is a killer. And what makes it a killer is that, first of all, you don't know you have it, and second of all, it metastasizes. So don't forget your ABC. Your A borders, your color, your
Diameter.
yes, the diameter is greater than 0.5, and E is that it's elevated. So just be reminded of what you learned in fundamentals. Okay, so ringworm is really not something that we have talked about before, but a couple of our students have come back from the NCLEX, and ringworm has been on the NCLEX. So we haven't really mentioned it much, but I'm going to go ahead and mention it to you. It is usually comes in a circular appearance. It's red. It's a little bit elevated here. And the thing about it is that it comes from the same group of organisms that cause athlete's foot. So ringworm is a bacterial. Impetigo is a bacterial infection. Now, the thing about impetigo, this was on the NCLEX as well, and so we wanted to bring this up. Impetigo it is so contagious. And what is so bad about these lesions, it's a bacterial infection. It usually comes from dirty fingernails, scratching dirty fingernails, that kind of thing. And it develops these weeping lesions. And the characteristic about it that describes impetigo crust is that it's this honey-colored crust that dries. But then if a kid goes to scratch it, then wherever he scratches, he's just smearing that grain into there, and wherever he smears it to, he's done it. So you'll find that they'll have 2 or 3 little spots on their chin, and then all of a sudden it's moved up around their mouth, into the nose. It is bad because it's so contagious. And so again, the characteristic impetigo is this honey-colored crust that develops after the lesion had a little bit of grain. Okay, cellulitis is something else that you need to be familiar with. It is bacterial infection of the cellulose in the body, and this is very difficult to get rid of. It's not impossible, but it does require long-term antibiotics. And then you have herpes simplex 1. Add in the lips up here. Herpes simplex 1 is above the waist. Herpes simplex here is below the waist. So you can just remember that. But look at these vesicles here. Fluid-filled fluid filled less blisters are called vesicles. Okay, so another thing that we're going to assess when we are assessing skin is that we are going to assess inflammation of the that we see on the skin. And so what is real important when you're assessing inflammation on the skin is that you compare the opposite side of the body with the side that is affected. So you're looking at the inflammation, the swelling there. Is there any warmth there? Is there a redness there? You're looking for all those signs and symptoms that come with it. And you're comparing it to the separate side of the body so that you can, the opposite side of the body, so that you can determine how bad that inflammation is by observation, palpation. Okay, so one thing that we assess also when we're assessing the skin is the color of the skin. So we look at cyanosis here. In general, healthy patients with naturally dark skin have a reddish undertone to them, and they'll have very pink mucous membranes. And when we're talking mucous membranes, we're talking about the inside of the mouth and the tongue and underneath the fingernails. The lips themselves will have this nice pink color to them. But if a darker skinned person is pale, then the mucous membranes will have an ashen gray color to them. And the lips and the nails will appear pale. So it's kind of hard to describe with darker skinned people because you don't know what their baseline is if you haven't had them as a patient before. So if you can't tell if the color is appropriate for ethnicity, then what you need to do is look inside the mouth at the mucous membranes, look at the cyanosis is a bluish discoloration of the skin, and it can indicate cardiac problems or pulmonary problems or even a perfusion problem. Now, the best place to inspect for cyanosis are the lips and the nail beds and the conjunctiva and the palms of the hand. Again, for darker skinned people. Now, there will be different places that the bluish discoloration becomes visible, and it's all dependent on how hypoxic they are or the length of time that they were hypoxic. So the greater the area that has this bluish discoloration, the more hypoxia or worse hypoxia they have. Now again, when you are assessing color changes in a darker skinned person, then you recognize that the lips may be a little bit darker and there may be a dark line along the gingival margin around the roof of the mouth, not the roof of the mouth, but the around the tooth line. You try teaching. Come up with your own expressions. I don't know. Anyway, you need to examine again the nail beds, the palms, the soles of the feet, or a bluish tint. We're looking specifically for a cyanosis. If you find those symptoms, then, let's say that you go and you see something around the lips, then you want to inspect all areas of the body to see if there's any further sign of hypoxia. Okay? All righty then. So one thing I wanted to point out, though, that acrocyanosis is when you have bluish coloring of the distal extremities, upper and lower, of a newborn baby. That's normal. So if you see that with a newborn, they haven't really had time yet to have equalization of the perfusion of their body yet. So it will be common for a newborn to have acrocyanosis of the extremity, but that's normal. Okay, so jaundice is another thing that you may see at some point in time, and with jaundice, you can suspect that a person has some kind of liver problem. And so lecture here. All right, so cyanosis, we've talked about cyanosis. Now we're moving on to jaundice. Okay, so with jaundice, again, there's this yellow coloring to the skin, tinge or hue to the skin. So what is happening here is that there is some bile that has become obstructed in the GI tract somehow, and so the bile is now coming into yellow. Now, to ensure that what you're looking at is in fact jaundice, you haven't just eaten a bunch of carrots lately. What you want them to do is look inside the mouth, the oral cavity, and look up at the hard palate. Remember, the hard palate is in front. And also you want to examine the sclera, and you want to examine the sclera nearest the pupils, because there are fat deposits that can develop on the sclera, and they can occur around the corners of the eye, but they will could have a yellow hue to them as well. So what we're looking for is the sclera itself turning yellow, not these little fat deposits sitting on top of the sclera have a little bit of yellow to them. But jaundice is usually indicative of a person having hepatic failure. So we want to check for the tinge in the oral mucous membrane, especially the hard palate, and the sclera is the best place to check for jaundice, but want to go near the center of the eye and not the lateral aspects of the eye. Okay, with internal bleeding, again, you have to compare the affected area of the eye with the same unaffected area on the opposite side of the body. What we're looking for is a darkening of the skin in darker skinned people, or a bruising, like a type of bruising, or petechiae. If you look around the conjunctiva, you'll see that petechiae, those little dots there. So all aspects is really one. Okay, so when we look at elderly people's skin, we're going to see that it is much more fragile. You saw mine, it's a lot thinner. So it's much more susceptible to injury. It's going to be a lot drier because of decreased productivity of the sweat glands. Of course, it's a lot thinner because of the loss of subcutaneous tissue. So just those will be normal findings, but does that mean you don't document it? No, you go ahead and document everything. All right, let's move on to the hair. So with hair, you're just like you did in your baseline assessment, your comprehensive, I guess it was a comprehensive guys, but for comprehensive, we're looking for the distribution of it. We're looking for its luster. We're looking for its texture to see if it's dry and brittle or soft. We're looking for the absence of it. Alopecia is what it's called when a person is exhibiting hair loss. Or hirsutism is what is called people that have excessive hair over different parts of their body. On the top of their head, it can be on their face, it can be on their arms, it can be on their body, even though a lot of men have chest hair. Excessive growth of chest hair. That is called hirsutism. I'm sorry. If lesions or lice are suspected, then we definitely want to use disposable gloves. This is what nits look like. Found in the hair. Has anybody had? I can't read your answer, so you'll have to answer. I had a kid with lice. Let me see. Okay, it's disgusting. I'm just telling you. I moved to California when my daughter was 5. I had 2 daughters. Both came in. Well, the first week there, they came home. And they were just towheads. Both of them had white hair. I don't know what it is. It just gives you the willies when you have these little bugs in their hair or these nits that are part of the shaft. Well, they have comb. First of all, they have shampoo. They have little combs that you're supposed to comb these out. Did I resort to that? No. I did the shampoo, but I took those little girls of mine and I set them on the back porch, and I took a pair of tweezers and I plucked every hair shaft that I saw that had a nit out of their heads and let it fly away. Oh yeah, I was not going to risk. So it would take hours to go through their hair and get rid of them, but that's all. Sorry, it just was traumatic for me. And it is psychologically, it's very traumatic because you associate pediculosis. I don't want to know that term, pediculosis, with dirty people. And I don't know why I did, but I did. Sad and traumatic. All right, the next thing we're going to look at is nails. Nails we're looking at the nail's color. We're looking at their shape. We're looking at their angle. Are they hard? Are they soft? Are they brittle? Are there any lesions surrounding that? Normally, nails appear very pink. They're hard, the nails are, and as a person gets older, the nails may turn kind of a yellowish color, and they may thicken, have ridges in them. But just know that there is a definite look to abnormal nails. Look at So first of all, clubbing. Clubbing is indicative usually of a long-term hypoxia, often associated with COPD. People that struggle with having enough oxygen or getting enough oxygen. So that's clubbing, and this is what clubbing is right here. And over here, this is called spooning. Or kolonychia. Kolonychia. Does it matter? No. Why? Because I call it spooning. But anyway, this is often associated with iron deficiency anemia or uncontrolled diabetes. Oh, this is my favorite. My favorite. Yeah, it is. It's those yellow, thick, crusty nails that old people have. Well, some people, young people have it too. But this is usually fungal infection. Tell you this because they're just yellow and thick, flaky. And there is medication that you can put on these. But what you have to understand is that number one, it's long term. What it's doing is killing the fungal or the fungus that the lotion medication comes in contact with. So you kind of have to keep applying the medication every day until that nail grows out. And the new nail should be free from fungus because you can have and so the new nail should be just fine, but it takes a good year for those nails to grow completely out. The problem with the medication is that it's highly toxic to the liver. So even though you're putting this on the nails, you're getting a little bit around because it'll be absorbed by the skin when it's exposed. So this is just not a learning thing. That is that back in Oklahoma, the ICU people, doctors with this, they would not prescribe the medication toxic to the liver, but they prescribed mentholatum. Mirror the mentholatum on those little suckers on each and every toe. You wear socks to bed at night, and it still takes a year for those nails to grow out, but it's not the medication cheap and it's not toxic to them. Okay, what else we got here? All right, so this is a picture of white lines grow down. If you can see them, then usually it's a result of some kind of trauma. White spots on the nails like this. Then black nail indicates that you have hit this somewhere. Hurts like hell, and there's blood that is accumulated underneath the nail, between the nail bed and the nail. So as that blood accumulates, it puts pressure on the nail. Also on the nail bed, so it causes the result of some kind of trauma. And then Bowes lines are an indentation that can reflect acute illness. And then peronchia is where there's an infected around, usually at the base of the nail. Right here, this little line right here, it's called a splinter hemorrhage. A round streak in the nail. Okay, so as we end this lecture, we're going to look at what are the different things that you can do for this person. And just some of the things that we're going to talk about, things that you can do for common skin disorders. So there's topical agents that can be used. Sometimes it requires systemic antibiotics. I know this happened to me when I was pregnant. I had this rash under my nose, and I thought, oh, I got some hydrocortisone cream in the bathroom. I'll just use that. So it take the inflammation of that rash down, but the rash never went away. In fact, it grew, but it took the inflammation down so you couldn't see it. So after about 5 months, and the rash had grown pretty wide and it was getting darker. I went to the doctor finally, and yeah, well, my little rash had become addicted to the cortisone cream. And so, yes, it was going down with the inflammation, but it was not curing the rash, bacterial infection. So he said, so what's going to happen here is that you've got to get off that cortisone and let the antibiotics work. And so I had to get off the cortisone. And oh my gosh, just stick a knife in my eye. It was so painful. It just burned. It got so hot and it got so red. So what I had been trying to avoid for so long was the appearance of something wrong with my face. It just inflamed down. And just getting that, the inflammation process, controlling into but the bacterial infection took 2 or 3 weeks. Antibiotics. So sometimes systemic antibiotics are necessary to kind of skin disorder. Peeling, a microderm is benign lesions for you. Scars, injection, dressing. Oh, I think it's talking about the rest of the body. So if there's different kinds of lesions there, different dressings can. Okay, so these are things that you want to do, and I'm not going to spend a lot of time on them, but notice at the top of every slide here, there is a nursing diagnosis. So you have impaired skin integrity related to rash or lesion, secondary to scratching. So you would, these are the nursing regularly. Cleanse the area as ordered by HCP. I was given very specific instructions on how to care for that rash. Provide cool, moist compresses, pat the skin dry rather than rubbing. Apply topical agents. Time. A high protein diet for healing. Now, disturbed body image related to visible rash and lesions. Sometimes very traumatizing or embarrassing. Oh my goodness. You guys could just see some of the conditions that I had that manifest through lesions. It's disturbing to look at, but it is so, patients so self-conscious. They know you're looking at them. Very hard on them, psychosocial growths or nodules that are all over the body. It's very, very heartening for them. So how the patient to verbalize their concern, refer to a support group, display an accepting attitude while caring for skin lesions. Now, people looked at several lesions today that were underneath the skin. Palpable, but they were not open. They did not breach the integrity. So don't be afraid to touch people. Don't be afraid. I have seen not offer the hand to touch. It just further exacerbates. So that is one thing that's really hard with noticeable. deficient knowledge related to disease and treatment. So this is again going to be interventions: instruct, advise, encourage, teach. So a lot of the interventions. Education. When you have test questions, diagnosis, you have to look at interventions that specifically address the diagnosis. So again, knowledge, education. Oh my gosh, that's it, people. We ended early. All right, I know it's early. Tomorrow we are going to do sensory in the morning, and Chantel's going to follow up afterwards with pediatric sensory. So that's what's on the agenda. Oh, we have 3 presentations. Are there any questions about today? Breakthrough. All right, then. I will see you, and tomorrow morning, text me with any questions that you have. I'm so appreciative of your patience, and we'll talk later. Okay? Okay.